Good evening, folks. I have discussion tea for you. Okay, now we're discussing loneliness policy is long-term policy, long-term care policy. Here we go with the presentation I made for you. Please enjoy. On winter mornings in northwest Pennsylvania, the light comes slowly. It slips through the blinds. In long-term care rooms, like like a hesitant visitor touching the metal bed rails, the plastic water pitchers, the framed photographs of grandchildren who now live 3 states away, and one of those rooms. In one of those rooms, a man named Harold used to sit in his recliner before breakfast, his hands resting on the armrest as if waiting for something to arrive. He'd been a machinist, the kind who could listen to a piece of equipment and tell you what was wrong before anyone touched a wrench. But in the nursing home, no one needed that skill. The world, he knew, had shrunk to the dimensions of his room. The schedule taped to his door, and the staff who rotated through with kindness but relentless efficiency. One morning, when I asked how he was feeling, he said, "I miss being part of the noise." That sentence has stayed with me. It is the quiet truth of long-term care. People don't just lose independence, they lose the hum of belonging. Loneliness becomes not an emotion, but an atmosphere. And now, as national leaders begin to treat loneliness as a public health crisis, we have an opportunity to name what Harold and so many others have lived. Loneliness is not a personal failure. It is a structural outcome of how we care for older adults, which means loneliness policy is inevitability. Long-term care policy, where loneliness takes root. Loneliness doesn't arrive suddenly. It accumulates like sadness or like sediment. It begins with the loss of a spouse, then a driver's license, then a familiar neighborhood. It deepens when hearing fades, when mobility slows, when friends die, when adult children move away. By the time someone enters a nursing home or assisted living facility, loneliness has often become a companion. But long-term care environments designed around safety, regulation, and clinical thought put can unintentionally harden that loneliness into something more dangerous. The daily rhythm becomes predictable but not personal. Activities exist but don't always connect. Staff are kind but rushed. Families visit but not as often as they wish. Loneliness becomes the air people breathe. Policy can change the air. The emerging national focus on loneliness is not just a cultural movement or moment. It is a chance to redesign the places where older adults live out their final years. Loneliness as a measurable risk. Imagine if loneliness were screened the way we screen for depression or fall risk, not as an afterthought, but as a vital sign. Harold's quiet suffering would not be visible, it would be documented. Addressed and followed. This is where loneliness matrix becomes transformative, turning an emotional experience into something the system is accountable for. Reimbursement for connection. Policy can make connection financially possible. Adult day programs, transportation, hearing loss treatment, and the friendly visitor programs could be funded the same way wound care or physical therapy is in rural communities like Meadville. This could mean the difference between isolation and belonging, exactly the kind of shift explored in long-term care policy, a workforce trained in relationship. Loneliness policy implicitly asks us to value relational care, not just not just tasks, but presence. Staff trained to sit, listen, and connect. Staff staff who understand that a resident's story is part of their care plan. This is the heart of relational care models. facilities as community hubs. The national strategy calls for strengthening social infrastructure. Long term care facilities could become places where the community comes in, students, volunteers, musicians, faith groups, and where residents remain part of the world beyond their walls. Technology as a bridge, not a barrier. When policy support technology can help residents attend church services, join book clubs, see grandchildren's faces, or participate in community events from their rooms. Connection becomes accessible, not aspirational. The stakes are human. Loneliness policy is not about matrix or mandates. It's about whether people feel known. I think of Harold again. What he needed wasn't a new medication or a different diet. He needed to feel part of the noise, to feel that his presence mattered to someone. Loneliness policy, if done well, can make that possible. It can turn long-term care into a place where older adults are not just cared for, but connected. This is the heart of the argument. We cannot solve loneliness without transforming long-term care. We cannot reform long-term care without confronting loneliness. They are the same project. Loneliness is no longer just a social concern. It is now recognized as a public health threat with mortality, impacts comparable to smoking 15 cigarettes a day. When federal leaders elevate loneliness to a level of a national health priority, the implications for long-term care are immediate and profound. Older adults in nursing homes, assisted living, and home and community-based services experience the highest rates of social isolation in the country. Any serious loneliness policy must therefore become long-term care policy. The question is not whether loneliness belongs in the policy arena. It is whether policymakers are willing to confront the structural realities of long-term care that make loneliness almost inevitable. Loneliness as a formal quality domain. The most consequential shift federal policy can make is to treat loneliness as a measurable, reportable quality domain. CMS already requires screening for depression, cognitive impairment, falls, and pain. Loneliness belongs in the same category. A policy forward approach would integrate, validate loneliness and social isolation measures into the minimum data set, or MDS, and the HCBS with home and community based services. Require facilities to include social connection goals in care plans.